All right, it is noon. It is officially afternoon, folks. I'm so excited to be introducing Dr. Erin Accurso, one of our own. So thank you so much for taking the time today to share about your amazing work. Dr. Erin Accurso is an associate professor in the Department of Psychiatry here at Behavioral Sciences and the clinical director of the UCSF Eating Disorders Program. She obtained her BA in psychology from Dartmouth College and her PhD in clinical psychology from the San Diego State University, University of California, San Diego Joint Doctoral Program, after which she completed a postdoctoral fellowship at the University of Chicago, specializing in eating disorders treatment and research. She's interested in mental health service delivery and improving access to effective care, particularly improving the accessibility of evidence-based treatments for underserved minority populations. Her research focuses on dissemination and implementation of evidence-based practices for eating disorders in community-based settings, particularly for underserved minoritized populations with public insurance. Please join me in welcoming Dr. Accurso. Thank you so much for being here, and I will go ahead and mute and pass the mic.
Thank you so much, Barbara. Just to check, is the audio okay?
Sounds good to me.
Perfect. Okay. Well, great. I'm really excited to be presenting and sharing some of the more recent research that I've been doing with kids with eating disorders who have public insurance. And I'll be sharing a couple different pieces of projects today. So just as a broad background, making sure that we all are familiar with eating disorders. I'm sure everybody is. These are psychiatric disorders characterized by pathological eating and related behaviors, as well as disturbances in the experience of food and body that cause either distress and or impairment. Lifetime prevalence estimates for eating disorders range somewhere between 8 and about 10% in young people. This was a sample of girls, teenage girls specifically, that looked at different rates of eating disorders, with lower rates for restrictive type eating disorders like anorexia and atypical anorexia and higher rates of binge eating disorder. There we go. Okay, good. There are also relatively high rates of co-occurring psychiatric problems in young people with eating disorders, in particular mood disorders like depression. People with eating disorders are much higher risk for suicide. About 1 in 5 with anorexia end up dying of suicide. There's high rates of anxiety and obsessionality, relatively high rates of substance use disorders and problems, and also very high rates of trauma. So most of the research that's been done to date in eating disorders has really focused on kids with private insurance. And so what I'm going to present in terms of background research that's been done is really what's been done primarily in commercially insured kids. So about 40% of young people with anorexia who seek treatment have had an eating disorder related hospitalization. Of those who require medical hospitalization, about half will end up being re-hospitalized within the year. So this is a relatively acute population, often requiring significant medical care. And we also know that there are relatively high rates of relapse, up to about 50% within the first year. And this repeated relapse can lead to repeated use of services over time, both medical and mental health services, as one of these disorders that really cross both realms. We also know that rates of death, mortality are relatively high, especially for those who have had a hospitalization for anorexia. You can see kind of what's expected here in terms of various ages in orange, and then in the aqua color, the actual rates of observed death, so much higher. About a 6-fold increase in mortality for females specifically with anorexia, most of whom in this sample were in kind of the older child to teenage range. Okay, so many of you are probably familiar with this, but I really want to emphasize this point. Eating disorders transcend race, ethnicity, gender identity, sexual orientation, age, socioeconomic status, body shape and size. I think even though cognitively many of us know this, there is often still bias in how diagnosis and healthcare delivery is provided. And this myth really is still pretty prominent in our society. Eating disorders really affecting primarily affluent white girls. That's just not the reality of what the data show us. Males actually account for about a third of eating disorder cases, a little bit lower in anorexia. And we know that rates of eating disorders are actually relatively similar across racial and ethnic groups, and also across socioeconomic levels. So we see eating disorders across the range of our full population and identities. And actually, some of the more recent research has been finding that prevalence has been increasing more rapidly for individuals with lower SES among males and also among transgender individuals. And we're also seeing some of that being mirrored in data in hospitalizations, where we're seeing more increases in Medicaid paid hospitalizations compared to privately paid hospitalizations. Okay. So why focus on our public healthcare system, and what is the context of that system? So Medicaid actually pays for most of the mental health care that is delivered in the United States. So it is the biggest provider of mental health services in our country. And yet, I don't know that there's really been very much, if any, research that's focused on publicly funded services within eating disorders. Certainly, a lot of other people have made their careers focusing on the public healthcare system for other types of diagnoses, but we don't really know that much about what eating disorders look like in the public healthcare system. But we also know that mental health providers who work in these settings and publicly funded settings really tend to lack quite a bit of eating disorders expertise. Many of them report feeling pretty unconfident working with these patients, feeling like they never received training in eating disorders, and I'm feeling like this is something more specialized, and oftentimes buying into this myth that, well, these aren't the kids that we see, or these kids don't present to our settings, which again is kind of part of that belief that has really been reinforced over time, because these kids are then not identified and then don't receive services. And so these stakeholders, clinicians, administrators, they may also share this perception that eating disorders don't affect low-income, ethnically, racially, and linguistically diverse youth. And in the research that's been done to date, we really haven't seen this population represented, which is a huge disservice to understanding the full context of people with eating disorders. So there's a lot on this slide, but I did want to kind of walk through my conceptualization of what happens in the public system of care. So we have on the left, all these kids with eating disorders. Most of them end up not presenting for care, kind of going downward in this arrow here. The diagnosis is then missed. They then receive no treatment. Likely, if they receive no treatment, they probably don't improve or may deteriorate. Some of those kids don't receive treatment, may end up dying. Some of them may end up going to the hospital. There's sort of a very lucky few who end up presenting for care, either because they were maybe referred by the school, self-referred, or they presented for a PCP visit where the PCP was concerned. An even smaller number of those end up getting screened for an eating disorder. Most of them will not end up getting screened. That will lead to a misdiagnosis and down kind of the same gray path. If they are lucky enough to be identified and diagnosed, there's kind of a few options. Some of them won't receive a referral for treatment. Some of them may receive a referral, but it's not really for appropriate care, or the care is incomplete, or there's really no appropriate resources available, and so they're not able to access care. So a very lucky few will kind of stay on this top line here, being referred to appropriate care, both on the medical side and on the psych side. And then from there, only some of them will end up engaging in treatment. Sometimes the treatment is not available, or it's not initiated, or for various other reasons, the family's not able to engage. And then even if they end up engaging, some of these families or young people will end up dropping out of treatment and not getting the care that they need. So I'm going to be talking about the kids within these systems who are actually identified and what we know about them. Okay. I've heard in talking with my work with counties, quite a lot of this unofficial, like, don't ask, don't tell policy in these mental health systems, because they don't really have a lot of resources for treating kids with eating disorders. And as a result, they don't really want to know if someone actually has an eating disorder. So it creates this really vicious cycle where they're purposely not screening in an intensive way for eating disorders. because if they identify an eating disorder, they don't really have the right resources to send them to. And when physicians are seeing kids with eating disorders, they don't typically diagnose and kind of place in their chart an eating disorder diagnosis because they don't feel that they have the time to really do that. So oftentimes they're documenting some of the medical consequences, and we may not see kind of an official eating disorder diagnosis, even if that young person is being followed for an eating disorder. In some of my work with Partnership Health, which manages care across 14 counties here in California, they found that only 30% of those youth who did have a new eating disorder diagnosis had a medical follow-up scheduled within 3 months of that diagnosis. We would not consider that to be sufficient medical care, but again, that's the context of a lot of the public healthcare system here in the state. And so there's really kind of this absence of evidence-based, publicly funded outpatient mental health care. On kind of our medical side here at UCSF, we end up seeing these kids oftentimes coming in and out of the hospital, not connecting to care within their county, relying then on hospitalization again and again, unfortunately. And it's a really vicious cycle that doesn't improve without improved outpatient services. Okay. So now I'm going to jump into talking about the data that we have. We got some data from the state of California to be able to look at, who are the kids who are being identified with eating disorders and what do they look like. So we have this Medicaid data set from the state of California over a 3-year time point. So between 2014 and 2016, these were kids between the ages of 7 and 18. And all of those beneficiaries who were covered under Medi-Cal at any point between those years was about 5 million kids. We took the population of kids who had either a primary or secondary eating disorder diagnosis at any point between those 3 years, which was about 8,000 kids. And then we selected kids with other types of psychiatric disorders to be able to understand how those kids compared. So we had a primary or secondary group with either an anxiety or mood disorder, disruptive behavior disorder, or psychotic disorder. Okay, so just focusing in on those kids with eating disorders, on average, when they received their initial diagnosis at any point between 2014 and 2016, they were on average 14 years old. Not surprisingly, about 70% female. That's pretty typical for what we see in eating disorders populations. And half had Spanish as their preferred language. So this is pretty different than I think most eating disorder populations that have been looked at before. You can see the majority of those with eating disorders with Medicaid insurance were Latinx. This is not particularly surprising given that most individuals in our state with Medicaid are Latinx, except that, again, this is not typically what we see in the research that's been done to date in eating disorders. About 20% were white, and then much smaller proportions of other races in that mix. And I'll talk a little bit about how those are likely underrepresented from what they should be. So white youth with eating disorders were actually somewhat overrepresented in this sample compared to the kind of their total makeup in the Medicaid-insured population, which is closer to about 15%. So again, this is not surprising and sort of bears out the myth that sort of perpetuates diagnosis, where kids who are white are probably more likely to get a diagnosis because they quote unquote may look like somebody who could have a diagnosis. But there was relatively low representation of youth who were Black or African American, under 4%. They were most likely to be diagnosed with other eating disorder diagnoses. And in looking at those diagnoses, most of them were actually pica, and much less frequent than AN and unspecified feeding and eating disorders. So these kids are really not being appropriately identified in the public healthcare system because we know that kids who are Latinx and Black or African American have relatively higher rates of certain eating disorders like bulimia and binge eating disorder. And so there's definitely a racial and ethnic disparity here in terms of diagnosis. But there was nearly proportional representation of Latinx youth with eating disorders compared to the whole Medicaid population within California, and the high rates of Spanish language really stand against sort of the usual underrepresentation reported elsewhere, including in the other psychiatric samples, which I will share. So Latinx and Spanish-speaking youth comprised a significantly larger portion of the eating disorder population compared to the other diagnostic groups, despite this coming from the same population. So in other groups, representation for kids who are Latinx was between 40 and 54%, Spanish speaking much lower, around 30 to 40%. And so we are seeing that more cases are being identified for Spanish speaking with eating disorders compared to other psychiatric disorders. Okay, the other thing that was really striking about these data is that about half of the eating disorder diagnoses that were given were completely unspecified. When we think about unspecified eating disorders, we tend to use this diagnosis maybe in an emergency setting like the ED, or some other type of setting where it's, you don't have enough time to really do a comprehensive assessment. It's not meant to be a permanent diagnosis. It's meant to sort of be a placeholder, identify that someone has an eating disorder, and eventually have a more specific diagnosis that's given. However, over the course of the 3-year period that we had data, almost all of those who received this unspecified diagnosis kept their unspecified diagnosis the last available time point in the 3-year period. So 84% never received a more specific diagnosis over the 3-year period. So it's really hard to understand what eating disorders made up this group specifically, but just to note, about half of the diagnoses really were not adequately specified in the way that we would hope and expect. Rates of anorexia were about 15%, bulimia about 10%. And then we had these other groups, other specified feeding and eating disorders, which might include things like atypical anorexia nervosa, although not during this time period. And then other eating disorders, which we lumped together because it was a relatively smaller group of diagnoses, which included binge eating disorder, pica, and rumination disorder. That was a relatively small slice of the pie. Okay, you might notice that ARFID is not on here. And I was sort of shocked when I looked at the data. I thought that there must be a mistake in what Medicaid sent us. And I checked twice with them, actually, because I freaked out the first time and then I freaked out the second time. ARFID was actually instituted as a diagnosis in ICD about 15 months before the end of the data collection period. So, they had 3 months to adjust to it and a whole year to identify and diagnose people with ARFID. There was not a single diagnosis in that entire 15-month period. It was actually pretty shocking. So I think that has changed at this point to some extent, but it did take people quite a while to start using this diagnosis. So we don't really have unfortunately, any data on kids with ARFID. They simply weren't identified. Okay. So we wanted to understand how well or how poorly eating disorders were being identified in these settings. So on average, per year, the total average number of eating disorder cases annually was about 4,000. So if you think about that number, it's not the number of cases that you might have with major depression or the number of cases with anxiety disorders, but certainly it's enough within our state on an annual basis that it's kind of hard to ignore. There are enough kids that we need to figure out how to serve them better. The total number of Medicaid beneficiaries between the ages, and if we calculate what we would estimate to be the national prevalence rates for this particular age group of about 5%, should have been about 50,000, 50 to 57,000 kids annually with eating disorders based on, again, national prevalence rates, which may actually underestimate. And in this analysis, we did not require for kids to be continuously enrolled across the year. We were very, very conservative, and we said even if they were enrolled for 1 month and they got a diagnosis, we will count them, which means that we're probably overestimating the amount of, or underestimating the amount of kids with eating disorders. So if we look at the actual counts compared to what we would expect to see in terms of prevalence, we're actually only identifying 0.2% of kids with eating disorders within the public context. And again, this is a really, really conservative approach because we included all youth, regardless of continuous enrollment, meaning that a huge portion of kids with eating disorders are not being identified in the public setting. And that's probably true also in other contexts as well. I don't expect that everybody with an eating disorder is being identified, but it's a pretty huge gap. So based on prevalence rates, eating disorders that are identified represent really just a small fraction of the estimated actual number of cases, about 4%. In other words, about 96% of eating disorder cases within the California Medicaid population may be undiagnosed and untreated. And even more conservatively, if we think about just the kids who would have presented for treatment, that rate is about 20%. It's probably lower in kids with Medicaid. So again, this is even still conservative, but assuming that 20% of them presented for treatment, our data still suggests that about 80% of those treatment-seeking cases are being missed and not diagnosed, despite having an eating disorder. Okay. So again, back to the various groups that we had here, that we had the full population of kids with eating disorders, and then we had random subsamples of kids with mood and anxiety disorders, disruptive behavior disorders, and psychotic disorders. And we made some comparisons understanding how kids compared with respect to some of these co-occurring disorders. We did adjust for age and gender because there were some differences to be expected in both age and gender across these four groups. And we found some pretty important differences in terms of co-occurring diagnoses that were maybe not picked up to the level that we would expect. So mood and anxiety disorders in kids with eating disorders was about 60%. We probably would expect that to be a bit higher. Kids with psychotic disorders were being identified with co-occurring mood and anxiety disorders at a much higher rate. If you look at, so that's kind of the mood and anxiety comparison. If you look at rates of PTSD, knowing that rates of trauma and PTSD tend to be relatively high or higher in young people with eating disorders. Again, you can see a pretty big difference between those with eating disorders compared to those with psychotic disorders, and no difference between kids with eating disorders and their rates of PTSD compared to kids with mood and anxiety disorders or disruptive behavior disorders, which we would certainly expect, and we're not seeing that borne out here in terms of identification of these additional disorders. Also, not probably seeing the rates of substance use disorders that we would expect in this population, and lower than some of the other groups. Again, I think these kids with psychotic disorders, and I'll share a little bit of these data, they were in a lot more services, they were being seen more frequently. My guess is that having more intensive care allowed for a more accurate diagnostic picture. And then again, relatively low rates of documented suicidal ideation. And again, it's not necessarily typical for someone to include this as a code in kind of ICD, but you would expect it to be included relatively comparably across the board. And you see pretty high rates of documented SI in kids with psychotic disorders, about 40%, but only about 13% in kids with eating disorders. And again, just based on our knowledge about rates of SI in kids with eating disorders, we would expect that to be quite a bit higher. Okay. So what does this mean in terms of, how do these kids look in terms of their service use? So we took a look at then inpatient admissions to understand what use of inpatient services look like. And we classified each inpatient admission as either primarily mental health related, if most of the claims within that admission were billed for with a mental health disorder, or medical, if most of the claims within that admission were medically related. So we have kind of total admission rates. For mood and anxiety, it was relatively low, about 15%. For kids with eating disorders, it was about a quarter. For kids with psychosis, it was relatively high, about a half of those with psychotic disorders had at least one inpatient admission. And then we looked at kind of how these compared for admissions that were more mental health related versus medically related. You can see for psychosis, the majority of those admissions were mental health related. And they still had a significant amount of medical admissions. With eating disorders, it was kind of split across the two, and with mood and anxiety as well. So you can see eating disorders sort of fall somewhere in the middle. Not as many admissions as, or not as many kids with eating disorders being admitted as those with psychosis. That said, 1/4 of youth in the sample of eating disorders, half of which were unspecified, had at least one hospitalization. That is pretty striking. Certainly a lower hospitalization rate in those with mood and anxiety, and much higher hospitalization rate in those with psychosis. But if we look at those youth who had a hospitalization, over 50% of rehospitalizations occurred within just 25 days of discharge. So those who were admitted were very likely to be readmitted in relatively short fashion. Again, thinking about kind of access to care, they were not really able to very effectively stay out of the hospital. And compared to the other diagnoses, youth with eating disorders spent many, many more days in the hospital over those 3 years, whether we're comparing just those with a hospitalization at all, or those across all youth with a diagnosis, whether or not they got hospitalized. So if you look at the table here, you can see the hospitalization rates, 25% for eating disorders on average over the 3-year period. That was about 2.4 admissions. And remember, this is not, we didn't have a sample of or a population of kids who we had 3 years of data post eating disorder diagnosis. Their eating disorder diagnosis could have come at any point in the 3 years. So many of them came somewhere around the middle. So this might be 2.5 admissions over about a year or so of them being kind of actively in the data set with an eating disorder diagnosis. And over those 3 years, on average, they spent 48 days in the hospital. A pretty significant amount, a number. Many more kids with psychotic disorders had an admission, but their admissions over the course of those 3 years didn't amount to nearly as many days, 16 days. So much different and kind of similar total number of days across mood and anxiety and psychosis. And then if you look at all kids with each of these diagnoses, not just those who are hospitalized, you still end up with a pretty significant difference of total days. For all kids with eating disorders, including all of the many zeros, for the 75% that didn't have an admission, on average, there was still a total of 12 days. You can see a pretty big standard deviation around that because some of these kids were in the hospital for a really long time, compared to about 9 days for kids with psychotic disorders. And then if we look at just the group of those who had an eating disorder, you can see again, pretty high rates of admissions, looking at all inpatient admissions versus mental health versus medical. You can see relatively higher rates for AN and BN, and relatively lower rates for some of the other eating disorders, but many of them were still experiencing admissions, and we're still working on understanding some of these differences, but preliminary data suggests that there wasn't really any significant difference between these subgroups of eating disorders in terms of their hospitalization rate. Obviously, we have some effects of power here, but it's we see relatively high rates across eating disorders for these admissions. Okay, so that's on the inpatient service use side. On the outpatient service use side, most of these kids across these diagnostic groups received at least one annual outpatient mental health service. So about 77% in eating disorders, about 79% in mood and anxiety, 90% in kids with psychosis. But the average service use yearly differed pretty significantly between the youth. So for kids with psychotic disorders, on average within a year, they had on average 47 visits. Pretty big standard deviation around that, 51, median of 30 visits in the year. That median is important because there was such a huge range of some kids who use services really intensively and other kids who use them less intensively. But the median of visits was 30. Compare that to eating disorders where the mean was 30 and the median was 16, quite a big difference, received about half as much service. And compare that to kids with mood and anxiety disorders that kind of look the same. They received about, on average, 28 visits, again, median about 16. So they're kids with eating disorders who have often pretty acute presentations are receiving relatively similar services to those with mood and anxiety disorders. Okay. So summarizing these findings, I think some of our next steps are really going to be to understand better some of the factors contributing to admission and readmission, and also understand the cost analysis for services. I think some of the systems that are currently in place in the public healthcare settings, they're struggling with how to manage these cases because many of them don't have expertise within their counties to be able to treat eating disorders. Some of them have contracted out. I should say we really don't have data on higher level of care use, which does happen, to some extent in these settings, because those charges can't actually be billed to Medicaid. So this is missing a whole, portion of the pie of care that's happening. And yet the care that's being delivered was actually pretty intensive in terms of inpatient services. So understanding the cost better, I think we'll be able to better support an argument for which type of model is going to work the best. But eating disorder diagnosis is incredibly poor in these settings, both in terms of specificity, with about half of the diagnoses not being specified, and in terms of the number, a ton of kids with eating disorders are being missed here. But this is a really unique population in that, these kids with eating disorders are diverse in the way that we would expect based on prevalence rates. But because our state is so diverse, we're really able to capitalize on that and understand better how do we deliver more appropriate services to this, highly diverse group that really represent a large enough group that we need to be addressing this more proactively. Outpatient mental health treatment utilization, not surprisingly, was relatively low. Who knows what type of services these kids were getting? That's something that we can look into a little bit more. Very, very, very preliminary kind of models demonstrated that kids who received access to a quote unquote sufficient dose of family therapy in the first month or so, kind of post-hospitalization, were much less likely to be readmitted. But we're still working on kind of those models, and we'll have more to share in the coming months. And inpatient hospitalization days were really relatively high. So again, just sort of speaks to the fact that these youth are really not being well served by publicly funded settings at this point. Okay. So that sort of wraps up the Medicaid data. And now I want to frame kind of the next problem that we're thinking about. So we know that family-based treatment, or FBT, is the most effective treatment for adolescents with anorexia and atypical anorexia. And yet there are very few clinicians who are actually certified to deliver FBT in our country. Only 1/3 of those are contracted with just one private insurance plan, and most of them really are contracted with just one private insurance plan. It's really unusual for these providers to be contracted with any insurance plans, and only 3 are contracted with Medicaid. So people who are certified in FBT really generally don't exist within the public healthcare context. That's not to say that they're not delivering FBT, but they've not been kind of formally certified in the way that a lot of providers are in the community, or more providers. And so there's this huge gap in access to care, to evidence-based care for kids with eating disorders. And the treatment that's available is generally not evidence-based. And that gap is particularly large for kids with public insurance. So what are we going to do about it? FBT is just not easily accessed. And why does this matter? FBT is incredibly effective, and it's also inexpensive. So in the first 10 weeks of treatment within FBT alone, receiving FBT results in a $13,000 savings per patient, simply by reducing inpatient days by over half. So, and that's compared to another specialized outpatient treatment. That's not compared to usual treatment. So if you think about the savings with FBT compared to usual care that's not specialized, that difference is probably even greater. And the medical care costs can be extremely high with the inpatient kind of revolving door care that we see, at least anecdotally here within our setting. Some of these kids have more admissions than we can count on 2 hands. And that's just not an efficient use of resources. It doesn't set kids up to be successful and achieve recovery. And yet there are really very few efforts to disseminate evidence-based eating disorder treatments to publicly funded settings in the US. So this is something that I feel really passionately about. We need accessible, cost-effective implementation strategies and methods for scalability and sustainability of evidence-based treatment delivery in these settings. Okay, so I'm going to share a little bit about an ongoing trial that we have going. This is a cluster randomized trial of training methods in FBT specifically for behavioral health providers in publicly funded settings. So this is the OPTED trial. We're working with 6 counties across California and 25 publicly funded agencies within those 6 counties. And we randomized these counties to receive either a live 2-day training in FPT or a self-paced online training in FPT with a 1-to-2 allocation. So we had more clinicians in the self-paced online training since this is a newer method of training, and we wanted more data about how that went compared to a live training. And knowing kind of what we've done previously with training and knowing that many of the providers who we work with in these counties feel like they don't quite know how to diagnose an eating disorder, we really included a lot of fundamentals in this training in addition to specialized knowledge in FPT. So we included lots of information about how to assess for eating disorders, overarching eating disorder treatment principles that kind of apply across different diagnoses and across different treatments, but really set the provider up to understand how those might work in FPT. But the primary focus of the training really was on FPT specifically. And we incorporated a lot of cultural adaptations that were consistent with key principles of FPT, but helped to anticipate some of the challenges and tailoring and adaptations that we had seen coming up in our prior work within these settings so that people would be better prepared for figuring out how to manage the common things that would come up in the context of treatment in a way that stayed really in line with the principles of FPT. Okay, so this is just a little overview of the treatment that we created. We had kind of the all-star team. Dr. LaGrange did some videos. I followed people around to their houses, went to Andrea Garber's house. This was all during COVID, so it was kind of crazy pulling this together. Amanda Downey did some awesome videos on medical consequences of eating disorders. We really set a lot of foundational knowledge for these clinicians so that they really understood what are eating disorders, what are the consequences of eating disorders, how do we assess for eating disorders, and then we provided more specialized content in FPT. So you can see kind of the modules that we have. We had kind of an overview of eating disorders, an assessment module, general treatment module, and then we really nailed into some of the specifics of FPT. So people were able to make their way through all these videos and get more information. There were some knowledge checks built in throughout. You can see kind of orientation to things. We had these in-action sessions that awesome videos from our team here at UCSF that we were able to use that people could actually see live. What did sessions look like and what did these principles look like in action? And all of these resources were also available in the live training. So the videos that were shared for people in the online training, we were able to show in the live training as well to make sure that the content that we were providing was really identical across the two trainings, but different pacing, obviously, in a different format. And then we made a really extensive resource center that, again, was accessible to all of the clinicians in both of the training groups. Clinician resources, they could search for things specific to Spanish language or questionnaires or different types of treatment tools like session outlines. We also created a whole library of things for family resources that they were able to access from here. And then we actually had a bunch of testimonial type videos from providers in San Francisco who had gone through training and had engaged in treatment with clients using FPT and sharing their experiences of what it was like to try to normalize some of the anxiety, as well as provide some hope that actually this model was quite effective. Even if not, I liked what one clinician said. She said it was a really easy model to learn, but it wasn't necessarily easy to implement. So they understood the concepts. It took some kind of working through and consultation to figure out how they would apply those. Okay, so similar to our Medicaid population, our clinician participants were relatively diverse as well, which was really great. Many of them spoke a language other than English, which was also really great because we purposely tried to recruit and emphasize wanting to be able to have clinicians who spoke multiple languages, given that we know language capacity is so important. And when we've had to work with translation services, especially this type of work, family therapy is so much slower. So we were really, really happy that we recruited a sample of clinicians where about half of them spoke a language other than English, many of whom spoke Spanish, but there were 7 different languages represented in total. And you can see it was a relatively ethnically and racially diverse group, about 40% being Latinx, about 30% being white, Asian 14.1, Black and African American about 7%, and then a kind of multiracial or other category. Okay, so most of the clinicians at baseline said that they really wanted to get the live training. It's sort of not surprising. So kind of a moderate or strong preference for the live training was about half, 46%. Compared to, there were some people who preferred or said they would prefer to get the online training, about 30%. But most people coming in were sort of hoping to be assigned to the live training. And we're certainly going to disappoint those people because very few of them ended up getting assigned to the live. But that said, most of the participants ended up completing their assigned training. So 80% participation rate, especially for a kind of online training that people had to really be able to make it through on their own in a pretty self-directed way, I thought was pretty good. And we didn't see any differences between the training groups in completion. Most of the participants agreed that the course objectives were met, pretty high ratings on that. And they reported relatively high training acceptability and satisfaction scales. And again, we didn't see differences across the two training groups on any of these measures. I think what really surprised us, though, was there was a significant difference in how providers felt about FPT, depending on which training they received. So on a scale that we've developed, the FPT attitude scale, the online training group reported significantly more favorable attitudes towards FPT than those who participated in the live training. And that difference was statistically significant and clinically pretty large, actually. And we also saw some differences in how clinicians rated the overall acceptability, appropriateness, and feasibility of FPT. These differences were not as large, but they were still statistically significant, where the online training group reported higher acceptability, higher appropriateness, and higher feasibility of doing FPT compared to the live two-day training that was done via Zoom. We also saw, again, not clinically huge, but statistically differences between the two groups in terms of their knowledge post-training. So we looked at a ton of different variables to kind of see how our randomization had gone. And really, there weren't any differences either organizationally or individually about clinicians, other than there was a small difference in years of experience with eating disorders specifically between our two training groups. So we did adjust all of our models for that. And we found that participants' knowledge significantly improved over time, which was great. That was obviously part of the goal. They had relatively low knowledge to start. They had good gains in knowledge over time. But those who did the online training learned a little bit more. They had a little bit more knowledge post-training than those who did the live training. And again, they were able to self-pace. Some of them did Zoom through it in the last few days that they had to finish, but many of them sort of took their time over the course of a couple of months to complete the training. And so they had more time to absorb the information. We also saw a difference in the comfort that clinicians had in treating eating disorders. So again, after we adjusted for eating disorder experience at baseline, there was an interaction where those who received the online training felt more comfortable in working with eating disorders post-training, whereas there was a bit of a dip for those with live training. We somehow scared them in working with these cases, where they became slightly less comfortable after the training in taking on these cases. Again, these changes are not huge, but they were statistically significant in our sample. We also found a few differences using the TCU eval evaluation, which looks at a bunch of different implementation outcomes, including expected utilization of the training, resources provided, interest in further training, and the amount of support within their settings for implementation. We did find that the online group endorsed increased probability of implementing the training after the training compared to the live group. And they were also more interested in obtaining additional training following the initial training than the live group. That said, following the training, we really didn't see a difference in those who indicated a desire to participate in the year-long consultation groups. So we saw similar rates of people wanting and being interested in doing that. And again, sort of surprised that we had such a large number of clinicians who decided to pursue that. So about half of our sample who were trained ended up wanting to do a year-long consultation, which is a pretty big chunk of time and not one that was compensated for them. So I think we had a pretty highly motivated sample of clinicians who, they were really excited about being able to serve this population that they hadn't really been able to previously. And this was the kind of additional level of randomization. So some of them received 12 months of expert consultation. And our wonderful team members, Dr. Sarah Forsberg and Dr. Lindsay Brewitt, are providing consultation to our clinicians currently. And we'll be continuing to help with them with that over the next 6 months. And then some of them received 6 months of expert consultation, followed by 6 months of peer consultation. They're just now transitioning to the peer consultation phase. And I think our goal in doing this is trying to understand how can we do this in a way that's sustainable, that's most cost effective, because 12 months of expert consultation is not going to be available on a large scale basis. So we did a little tweak to see how much we could cut back on cost and still have clinicians be able to learn this treatment and be able to implement it. The groups are ongoing. Obviously, we have a lot of lessons still to be learned, but looking forward to seeing what comes out of these groups. So overall, I think my hope was that the online training would be as good, or at least good enough, compared to the live training group. But we actually found it was more effective in some post-training outcomes, which was a bit of a surprise. These clinicians were significantly more comfortable treating eating disorders. They had significantly greater knowledge, even though that was a relatively small difference. And they had significantly better attitudes towards FPT as a treatment modality. So feels really promising in terms of the potential application of online training for this type of these clinicians in these settings. The online training was acceptable. It was feasible. They had relatively little eating disorder knowledge to begin with. They were able to learn quite a bit. And again, we didn't see differences in the live training versus the online training and wanting to proceed with more consultation. But that said, we still, the jury's still out on how the different trainings are actually going to impact ultimate change in clinician behavior and ultimately clinical outcomes, which is what we care most about, is how kids are doing after they receive care from one of the clinicians who received training. So trial is still underway, jury's still out on that, but we're excited to be able to share more data on that in the coming year. So I think some of the key takeaways for me so far of kind of all of these sources of data, the population of youth with eating disorders who have public insurance, they've really been very ignored. And my hope is that bringing light to this issue will really help to increase awareness of this problem and help to close the current gap that exists in care. And we're also working simultaneously to address the gaps that are there currently, especially with this training trial, and really hoping to increase appropriate access to diagnosis and services. Our team has been doing a lot of trainings for community providers, PCPs, to help them better be able to identify and manage medically some of these cases, provide appropriate referrals, and ultimately improve outcomes for these youth. So that is a little bit about what I've been up to and some of the data that we have, and love to take any questions or have any discussion about things that people would be interested in.
That was fantastic talk and such needed work. So thank you for that. We have a question from Dr. Will Martinez. Are you still on Zoom with us? You can go ahead and unmute yourself. There you go.
Yeah, I'm on. Yeah, thanks, Barbara. And Erin, great presentation, and thanks so much. I believe this is an incredibly important topic and super relevant to the work that we're doing here at CAS at SF General. Question for you, and this goes back to the data about the prevalence rates, and sort of this is a two-parter. I hate when people do this, but I don't know how else to do it.
Well, you're going to have to do it one by one, Will.
Yeah.
I won't remember your second question if you ask them both at once.
So the first question is the data. So, a lot of the data you presented, it looks like this was managed care plan data. So it's like sort of primary care, and thus underestimates there. And sort of the first part of this is, do you think the numbers are equal, more or less so, on the specialty mental health side? Once they're there, are people better able to detect? And And the second part's easy is, are there plans to kind of maybe increase the education in primary care so that there's detection early of some of these concerns? Because we're seeing them come much, much later, and usually that is, and through schools, through other kind of sources of referrals, and not necessarily through primary care, unless they've been here at UCSF where folks are aware and screen, right?
Right. No, great question. So the Medicaid data that we had, it included any claim. So this could be from primary care. It could also be from specialty mental health. So any claim that was submitted to Medicaid would have been included in this data set. So that really encompasses all contexts of care for publicly funded services. The one thing it does not include is, if someone went out of kind of the county system for residential treatment or PHP or IOP, because there's no way to bill for that directly through Medicaid currently, that is not unfortunately reflected in the claims data. And so costs for overall care will be underestimated because we're not able to account for those services, but it definitely includes, like, the general some of those claims would have been from the general. So any bill that would have been submitted to Medicaid would have been reflected in these data. So that hopefully that answers the first part, Will, in the sense that it really includes, kind of general and specialty mental health care and medical care. All of that would be encompassed within the data that we received. And I have an ongoing project and effort with Dr. Amanda Downey in pediatrics and psychiatry to improve training for PCPs. So we've done a lot of interviews with PCPs, working with young people, trying to understand what are the main gaps in their knowledge, what are some of the things that they feel like they would need to know to be able to better manage, better screen, better assess for these patients. We've had kind of trainings ongoing over the past few years for medical providers, kind of first line. Our team does a ton of trainings in the community for schools and, trying to increase awareness, and it's not sufficient. So we do need to continue to find ways to, improve education, recognizing that people's time is really limited. And, in the context of a visit, I think a lot of physicians feel like, I just don't have the time to do this. And so we're trying to find the balance of how can they build this into an assessment that they already need to do. Many of them assess for diet and lifestyle habits. How can they build this in as something that actually, like most of the kids that they see, if they're seeing teens, are engaging in dieting behavior. So that is actually an important part of their assessment, right? And so how can they sort of build that into what they're already doing? But absolutely, I think that's a big gap that we need to address as well at the same time.
Thanks, Erin. Dr. LaGrange, Daniel, you have a question.
Yeah, question and a comment. Warm congrats, Erin, on taking evidence-based treatment in eating disorders to really a community of both clinicians and families that are so deserving of this work. So well done on that. I'm curious about what you make of the interesting findings between online versus in-person training. Having done a fair amount of both, I expected the dice to fall in favor of in-person. So I'm just curious what you make of that.
Yeah, I did too. I mean, that said, having done this kind of in the context of the pandemic and working with 6 counties who, were very distant from one another, it wasn't technically in person, right? I mean, it was live, but we did it via Zoom. And I think people are so burned out on Zoom trainings. It's hard to keep people engaged for that long. I also think, even though, again, the content was the same and basically delivered by the same, type of people, we didn't have the advantage of the amount of planning and thought that went into building an online training. As much as I've done these trainings, and Sarah Forsberg did the training alongside with me, and she's done a ton of trainings. There's some things that are unique where you can answer questions live and address those live, and I think that is really effective. But there were other things that felt more rushed than what we were able to deliver in the online training in the same amount of time. So it was sort of interesting to compare and contrast those. We were really able to address, for example, adaptations in such a methodical and thoughtful way that, again, we also did this, we delivered the same content, but somehow it felt different across the two trainings. And I think part of that is, the online training took a year and a half to put together. The live training, we spent the day before preparing, and we had all the same content, but it's not the same process, I guess.
Thank you. I have a couple of follow-up questions. But
I thought it was hard for people to stay engaged in the online, and they still did it. So
I have a couple of follow-up questions, but I'll step down. The other folks probably have questions too. I can chat with you tomorrow.
Thank you, Daniel.
Right.
And Dr. Lewinsky, go right ahead.
Erin, so one comment I'm going to make about your fabulous presentation is that had I known you were going to be in the auditorium instead of doing it remotely, I would have come. It's a remote day for me, but for anybody who's going to present on our team, from our team, please let us know if you intend to do that so we can show up for you. That's wonderful. So I have a question, Erin, because this is such important work, and it's really important work in the sense that there's a lot that we know. So there's a lot that we assume we know from studying populations that don't represent the populations that we treat. And so you're really pioneering important work in that respect. I have a question regarding the suicide issue. So, and it's actually two questions. So one of them is your understanding as an eating disorder specialist that this is a suicide that is mediated specifically by factors related to eating disorder, or is it mediated largely by this huge comorbidity with depression, with anxiety, or with personality traits that tend to correlate with suicide? And then the second issue is...
I'm going to stop you, Anne, because I won't be able to keep your second question in mind. So let me answer
go ahead.
the first one first.
Yeah.
I don't think it's that black and white. I think both of these things contribute. And, we see some of the highest rates in people with bulimia nervosa. But when we see suicidality in people with anorexia, there's some extent to that, which could be influenced by malnutrition. That can also be the case in BN. That can also be the case in binge eating disorder. Some of these things are, I think, physiological, biological, and then some of them have to do with the comorbidities as well, and just the amount of impairment and dysfunction that eating disorders can cause.
So a more granular look at that would be super important. And then the other thing is, when we say 20%, are we meaning in terms of people who have eating disorders in the general population, or do we mean in clinical populations, meaning they've been seen by a clinician? Because I think that's important too. Do we know that?
20% for what, Anne? Sorry?
Suicide for anorexia nervosa, 1 in 5. Like, are we talking about epidemiologically, or like people who are coming to clinical attention?
I believe those are epi data. Yeah, I would need to confirm that, but I believe those are epidemiological data.
Yeah.
But it's a good question, because I'm not 100% confident, but I think it's epi data.
I don't think I know for sure, so let's figure that out. But that's very important.
That'll be my homework from today.
Yeah. Thank you. This was great.
Erin, in the last couple minutes we have, you in your first slides, you spoke to the rising rates of eating disorders in certain populations, particularly children, youth, who are living at under the federal poverty line in terms of income, and transgender youth. And I'm wondering if you can talk a little bit about why that is, how the rate of prevalence is high, if you can speak to that, that'd be great.
Yeah. It's a little tricky to kind of tease apart how much of that is improved recognition and how much is true kind of epidemiological shift. I mean, that said, we know that there are a lot of factors that are encountered more often in people with lower socioeconomic levels, like food insecurity, that are demonstrated risk factors for the development of eating disorders. And those are going to be more likely experienced at lower SES levels than higher SES levels, although we know that food insecurity can impact, people across the board. That's probably an increased risk factor. And then I think we're probably not seeing any differences or change in transgender folks, but that research is relatively more recent. And so I think there's increasing awareness that population is at increased risk for lots of different reasons. And hopefully that research will also prompt, again, kind of us to be a little bit more proactive, more thoughtful in terms of screening, knowing that certain populations are at higher risk for these disorders.
Thanks for that. It is 1:00, sadly. So we'll have to end. It's fantastic having you speak to our community, Erin, and this is extraordinary work. Thank you for doing it. And have a good afternoon, everyone.
Thanks so much, everyone. Appreciate everyone coming.